I'm Dr. Srinivas Kumar here. We are able to see you and hear you. And please...
Good morning.
Yeah, go ahead,
everybody. So I think after the high-octane show from Indore, we are a more sedate show because I want to calm your nerves. Okay?
I'm joined by Dr. Ramesh, Dr. Sandeep, and many other colleagues here, madam. Oh, please introduce your case and go ahead with the case.
Good morning, sir. Good morning, Dr. Ramesh, and good morning, all the panel members. So I am joined here by my team, Dr. Anil Mahapatro, and doctors anesthesia support from Dr. Tapti, and then I have my colleague, Dr. Rakesh, my nurses. Can we go to the case? Inferior STEMI, we did the primary PCI. Can you show the screen of the, yeah. So risk profile dyslipidemia, he presented with inferior STEMI. We did a primary PCI. His, to the RCA, his creatinine clearance is 50 ml per minute. Can you show the angiogram? So the angiogram, we have ostial LAD lesion. You can see an osteoproximal LAD lesion with calcification, which is extending up to the mid-LAD. The diagonals are small, diffusely diseased. Then we have an interesting OM. Two OMs are diseased. One OM1, which is having proximal around 70-80% stenosis. We have an OM2, which is showing around 80-90% stenosis. Can you show the next? Next. So we did the RCA primary PCI. We implanted a 438 stent, and that is good. Can you show the final result? So this is the final result of the 438 stent. Can you show the angiogram, Ramakrishna? So that's the post-PTCA.
We saw it, madam. It's okay. The result was good.
So now we are going to the, now what to do with the LAD left, so this is the RCA. So come to the next, come to the angiogram. Come to the LAD. Come to the LAD. Next. Okay. So you can see there is calcification in the LAD, osteoproximal LAD. We know that we have to do complete revascularization. We are stuck at this stage because we already completed the right. So what do we do with the OMs? What do we do with the LAD? Should we implant the stent from the left main to the LAD? These are the questions before us. So should we do an FFR? Because we are moving away from FFR in case in ACS situations. But should we do an FFR in this situation where we have tortuous OMs? And can you show the next slide? So I would like the panel to discuss what should we do. Should we do the FFR of the OM? Should we stent from the left main across the circumflex crossover stenting, and the calcium modification strategy? So what are we going to use? Okay.
Basically, madam, if you have a doubt of stenosis severity, then you think of FFR, be it ACS or chronic, no? Here, I think lesions look pretty tight. LAD is definitely tight.
LAD we have...
Distal LCX also looks tight.
LCX.
OM and OM1 and 2 like.
So madam is asking about OMs, I think. Whether
OM and
yeah. I'm asking about OM1 and OM2. So what would your approach be?
They feel it looks tighter, they're saying.
OM1 needs to be fixed before proceeding to LAD crossover stenting.
Yeah, that's important point what my colleague is mentioning here. If you decide it, but before we have to finish it, if you do crossover again, it will create trouble to access left.
So you want to fix the small OM also below?
Ma'am, the primary PCI has been done in the same setting?
No.
No, sir. It has been done about 2 weeks back.
Yeah, then it's fine.
So now we finished the RCA 2 weeks back, and now should I treat the small OM also? It's a small territory. So these are the questions before us. So I'll show what I have done till now. I use the FFR wire. I use the FFR wire in the OM1. Can you show that? FFR in the OM1. I mean, I did the RFR. And you can see that it is 0.58. Show the pullback. Pullback, please. That's the pullback. So you can see that it is a pretty focal lesion. Next, we also did it into the OM3, that is the tight small OM. So that is the 0.37 pullback. So again, we got a focal pullback. We did it in the OM2. Next. OM2, so OM2 is not significant, so we have to fix the OM1 and the OM3. And what is the calcium modification strategy in the LAD?
I think as predicted my colleague here, madam, those OM 1 and 3 were looking tighter in angiogram and 2 were looking less. So angiographic assessment was proven correct by FFR and significant positivity. But it is always, we should also consider how big is the size of the vessel, what is the territory it is involved. Though FFR gives indirectly, if it is supplying more bigger, it comes positive. But if you are not wanting to touch OM3, it's up to you, madam. But the proximal one, I think, is pretty important, a larger vessel.
You want to stent the OM2, OM1?
OM2 came negative anyway, so only thing is whether to do OM3 or OM1. So if you think OM3 is smaller, we leave it to you. OM1 can be tackled, then you can tackle left main to LAD.
So do you want to implant a stent? Do you want to use a drug balloon?
I thought it was quite close to the main circumflex, so I would think drug-coated balloon would be a good choice.
This is Dr. Sandeep Bansal, madam, from Delhi.
Yeah. Thank you, sir. Because we were also in agreement with you and we did a drug-eluting balloon. I'll show the left main preparation. We were trying to, the present angiogram. So I'll show you what we have done till now. So we tried to pass the FFR, the OCT catheter. The OCT catheter did not cross. So we even tried to pass a Wolverine, it would not cross. So we dilated with a 2.512 at this stage. Next slide. Next. So we dilated with a 2.5, next. So this is the thing, we dilated with a 2.512 at high pressures. Then we did an OCT. I'll show the OCT run.
This is again important point for the beginners, though you would like to image it, but the imaging catheter also won't go if there's tortuosity and very critical lesion. Sometimes you need to make passage for it, and then OM3 also, I didn't see it before I was out. That also looks big and tight, man.
Yeah. So this is the OCT. You can see that the distal vessel was measured. Krishna is with me, he will explain. The distal thing, show the distal lumen is around 3.2. So then proximally, as we come proximally, you can see, though the calcium score is 4, we made very good dissections with a non-compliant balloon. So can you see the dissections? Can you see the OCT?
Yeah, very well.
We can see, madam. And there's definitely a huge amount of calcium.
Yes. The score is 4, sir.
Yeah.
And we measured, so are we going to stent to, do we need any further preparation strategy? So.
Yeah, I mean, here at 3 o'clock, there is a definitely calcified nodule as well. So, that is definitely a thick calcified nodule, and the score is 4. Whenever you have an OCT score of 4, meaning 180 degree of calcium or greater, 0.5 millimeter thickness or more of calcium, and more than 5 millimeters length of the calcified lesion, it's basically got 4. 180 degrees and more, 2 points, 1 point for 0.5 millimeter thickness, 1 point for 5 millimeters in length. That indicates that the stent under expansion will be much higher. If you implant a stent, actually the stent under expansion will be about 68% expansion. And so, whereas if without this calcium score of less than 4, you'll get an expansion of about 96%. So there'll be a 30% difference in the stent expansion in this region. So I would still prepare it further. Whether you
Yes,
want to
sir.
use a shock wave or even a higher non-compliant balloon, opium balloon or whatever you have, I think it's much better to use that.
Sir, in view of the dissections, and I thought I'll go with the Wolverine, sir. I used a 310 Wolverine. Can you show that? So, and I
That's
saw
good.
that the expansion is good. Can you
Cracks
show
are
the
also quite
angiogram?
seen very well in our
Yes.
city.
So you can see that I've got very good dissections at the left main ostium also. So at this point of time, do you want to, next, minus. So do you want to prepare further, sir? Do you think we are good to go with the drug balloon, go with the stent? Meanwhile, what I did was I also implanted, used a drug-eluting balloon, the Magic Touch balloon, a 2.535 in the in the OM1, and I dilated. This is after preparation, so this is the balloon.
Yeah. Yeah, that's the right choice. I mean, unfortunately, in the United States, we don't have
So this is after the balloon.
This is another important measure. What Madam demonstrated is drug-eluting balloon should be used like a stent. Preparation has to be done with a balloon before, and then take this and inflate it to nominal pressures. And according to the recommended thing, for 1 minute, you inflate it. And then result has come out quite okay, madam. People say that even if there are mild dissections, it's okay as long as flow is maintained with after DEB. But here it looks, result looks quite good and encouraging.
Yeah. So the question before me is to use another drug-coated balloon in the OM3 that I have not yet decided. And now, can I stent from the more important question is the LAD. Shall I stent it from now, or you want more preparation? Because in this view, I feel it is well expanded.
Yeah.
I mean, it's...
I would like to see another preparation in the LAO caudal view, exactly where you had
one minus.
a 3 o'clock calcium on the OCT that is corresponding to that 3 o'clock on
Next.
the LAO caudal view.
Minus. We've taken
And
one LAO caudal.
After
Minus.
preparation.
Minus.
Yeah.
This is the...
Yeah, so here that still see that 3 o'clock where that small diagonal is coming out, I would expect a stent under expansion to be at that point. So maybe you can take another, maybe larger balloon, or the same Wolverine also is fine one more time in that region.
Sir, you want me to use the 3.3? I have a 3 Wolverine. You want me to use the 3 Wolverine? I went up to 14. It's at 14, it is 3.3. Or you want me to take another 3.5 non-compliant balloon?
Yeah, 3.5 non-compliant balloon, madam.
This, no? So you want me to use 3.5 and then
Stent.
stent.
Right.
After stenting, I'll after taking care of the LAD, because the patient is having pain, I want to do the left main to the LAD first before I think about. Though I can easily use a drug balloon in the OM3, only the cost considerations are making me think.
Yeah,
That's the only reason I'm thinking.
Yeah, that would be for me stent.
Actually, this is the people who are, I was talking to the company to evolve a package where how many balloons are 2 or 3 per patient, you should charge per patient, because otherwise it's quite challenging to you open many balloons if they have multiple lesions. I think we need to talk to them further. I think you go ahead and do what you feel is right, madam, because finally choice is yours. And if you want, we'll just break for you, because the pattern is decided 20 minutes. Then we'll come back to you for again after 10 minutes so that we can work in peace. And we'll go back to the indoor and come back to you after 10-15 minutes. Is that okay, ma'am?
Okay, sir. Yeah.
Thank you. Can you connect back to indoor, please? Yeah, madam, we are back with you. You can show us briefly what you have done.
So I've done as Dr. Dagupati has suggested. I did a dilatation with a 3.5. The expansion was good. Ramakrishna, show that. Chubich. Do it here. The stent is not expanded.
Yeah, so Dr. Sandeep Bansal and I were chatting while you were doing that, whether if the patient is unstable and you have already pre-dilated, you can go ahead and put a stent, nowadays it is easier to make a recommendation like that because we either can post-dilate with OPN in India or shockwave, and in the United States we don't have OPN, so we can do shockwave
it's
if
dilated.
need be.
Do it.
But if the patient is stable, I would like to prep the lesion first, then go with the stent.
Sir, I put a 3.5 48. I did a pot, and then I'm doing the dot. So when I was doing I was trying to pass the 3.5 balloon. It did not cross. So I had to be bold and remove though I didn't want to do it. I was forced to remove the wire from the OM. So I did a pot and a dot. Now we are going with the OCT. We want to see the struts across the circumflex and then decide whether we want to intervene on the circumflex or not. Show meanwhile whether the pot and dot.
Yeah, sometimes these larger balloons, is a 6 French guide, right, madam?
Yeah, I took a 7 French,
7
sir.
French, okay,
I
okay.
took it through a slender sheath of thermo radial, and I'm with radial down.
Okay.
So I might have some problems in pushing things. So this is the stent. Show the stent expansion. This is the stent, sir. As you told, there is an under expansion there.
Yes. Yeah.
Next, then pot. Next, pot. Next. Go quickly. Then we started the dot. As I told you, when I was trying to push this balloon, I had a problem.
Okay.
So I was forced to remove the OM wire. So we'll do the OCT and see whether there are any struts across the circumflex.
Right.
Sorry, Brijesh managing the Zoom links. Sri Lanka hub has some problem in activating the Zoom account. Please check that, please.
I'm having difficulty. Yeah.
Yeah, I think imaging definitely helps us to make sure that we are getting the appropriate minimal stent area.
Yes.
Yeah, sir. We want to see that and we want to see the circle. So because I have not taken any injections.
Yes.
This is another important point. We can avoid taking direct injection because the OCT, when you're doing itself, you get
Now?
a good angiographic injection also. That saves some contrast. We have a tendency to check immediately, but that when you're planning OCT, you
Yeah,
can as well
now
do it.
pressure.
After.
Yeah, check. We are inside. Okay. Right? So we are taking the OCT run. So you can see the OCT run and tell me what I'll be doing. Krishna will be showing us what we've done, whether remove those. I think we did good preparation. Dr. Ramesh and Srinivas Kumar, Dr. Sandeep, what do you say?
Yeah,
Perfect.
this looks very good. Excellent. So, I mean, there is always yeah, that's an area where we were talking earlier, but I think it's still okay.
Can you tell the MSA there?
11.1, no?
Yeah.
11.7.
So,
I think even if we get a difference of about of less than 20%, in spite of best efforts, so maximum expanded
think,
area to less expanded area, it's
Yeah, this is very good. 6.92. We see that, you know, yeah, there is a little bit of under expansion towards the 5 o'clock right there, and that's okay. You know, with the area of 7 and that much of under expansion is not bad at all. It's very good.
in opposition also, struts also is quite good. Great job, madam. I think any final comment?
we just want to show the stents across the circumflex.
Okay.
Can you show the 3D view so that, because if my strategy is to look at the stents across the circumflex, and do only if there are any struts across the circumflex.
It's beautiful.
Otherwise, imaging helps us do this
No,
also
actually,
in bifurcation
fortunately,
lesion.
there are not many struts. Only one thing which is seen opposite side. I think perfect demonstration of LCX osteum by OCT again. That's the beauty of this technology. Thank you, madam. Congratulations.
I think that's fantastic. Yeah, we can go and look at the distal circumflex if you want with the direct stent later on, or in this setting, madam.
It looks like
Yeah,
a straightforward
I'll-
short lesion. You
yeah,
can address
perfect
that.
job. Excellent. Thank you very much for your demonstration.
Thank you, sir. Thank you very much for the inputs, and thank you for making me prepare the lesion, because most of the times we are so in a hurry to put the stent in. But Dr. Ramesh has pulled me back, made me dilate again. I went up with the 3.5, and now you can see the beauty of the MSA which I got, which is 6.9.
Thank you, madam. Great demonstration. Congratulations to you. Everybody is applauding your effort. Thank you again.
Thank you, sir. Thank you.